Hello, friends. We're talking on this topic, sarcoidosis. So there was an interesting case that we had in our ICU. So it's just a brief overview on the sarcoidosis, pathophysiology, and the symptoms and treatment. So I wish to thank my colleague, Dr. Kiran, who helped with this content. So the sarcoidosis is mainly a granulomatous disease, predominantly affecting the lungs. So basically, it is a systemic disease with the multiple granuloma formation. So the three important organs that are affected are lungs, eyes, and skin. So these are the three important organs that get affected. And these granulomas that form are non-caseating and they're non-specific to the disease. So and these granulomas can be present anywhere in the body. So it can be present in the liver or it can be present in any structure. But as I said, the main three organs or the tissues that would be affected is lung, eyes, and the skin. And as I said, the granulomas are non-specific. So the clinical outcome of sarcoidosis can have a big spectrum from having a very indolent chronic course, or they can undergo remission and they become asymptomatic. So they can have a chronic indolent sort of a progression, or they can just have a insidious onset and then they sort of resolve or remit. So etiology is not known. So there are infectious causes for sarcoidosis. So any viral infection or bacterial infection in a genetically susceptible host. So the key aspect is, since it's an immune mediated disease, so the host has to be genetically vulnerable or susceptible. So it can be due to infectious agent or non-infectious agent. And the infections that has been attributed is this Propionobacter acnes, and even exposure to Mycobacterium tuberculosis protein also can trigger the causation of sarcoidosis because it's predominantly immune mediated disease. Or there have been reports of exposure to some insecticides and pesticides and molds also as etiological component. So this is in brief about the etiology. So effectively, there's precise etiology is not known, but these are all the postulated sort of etiological reasons. With regards to epidemiology, it is present worldwide. So the highest occurrence of sarcoid is found in Nordic countries, which is Sweden, Norway, Finland, and these countries. The prevalence of this is 20 to 60 per 1 lakh population. And it is found to be a little higher in female population. And in females, the neurological manifestations and the eye manifestations seem to be a little more common. So the median age of the disease is 40 years and it has two peaks. So they can have a second peak in around 65 years of age. So first peak tends to occur in 40 years and there can be a second peak at 65 years. So this is the in brief about the epidemiology. So when you look at the pathogenesis, so there is this antigen presenting cells, which basically expresses the HLA. And this interacts with the T cell antigen receptors produced by the CD4 cells. So effectively, there is an interaction between the antigen presenting cell with an antibody through a HLA, and this leads to cytokine storm. So basically, there is a cytokine storm due to the interaction between the antigen and the T cells which interact with these antigen, producing cytokine storm. And this cytokine storm is what is attributed to lead to the production of the granuloma. So the granuloma formation happens secondary to the cytokine storm that happens. So the clinical manifestations, I've just tried to put it in a little pictorial form. So it can be asymptomatic. So sarcoid can be a very mild asymptomatic, and it can go to another extreme of presenting with the multi-organ failure. So the case we had in our ICU, and that was the reason we took an overview on this topic, who was a person who had multi-organ involvement and came in a very sick situation with a multi-organ failure and respiratory failure predominantly. So that got us interested in looking out into the cause, and she was referred from another hospital, and having visited few hospitals, including a rheumatologist who was looking after that. So we established the diagnosis in this particular lady, and we thought it's good to review the literature. So the symptoms can be non-specific. So non-specific symptoms are fatigue, night sweats, temperature, and some weight loss. So these are very non-specific. So specific symptoms would be related to more of organ involvement, either. So the common specific sort of a symptoms would be related to the lungs. So they can have cough, dyspnea. And our patient who presented in ICU typically came with respiratory failure with lung involvement. So cough and dyspnea pertaining to the lung, because as I said, lung is the most commonest involved organs in sarcoid, followed by the eye and skin. So these are the three organs which get predominantly affected. And as I said, the specific symptoms related to lung would be cough and dyspnea. Skin, I will take you through other manifestations. They can have maculopapular rashes, and they can have lupus pernio, and then they can have hypo or hyperpigmented, or they can have erythema nodosum. So very painful nodules can be present. So this is one of the picture. And the eye manifestations also are very common. So there's a lot of granuloma formation around the eye. So I'll just show you different eye pictures. Eye involvement in some of the cases can happen up to 70% of the cases. So they can have these granulomas on the conjunctiva. And then they can have anterior uveitis, which is very common. And then they can have granulomas in the iris. And they can have choroidal and retinal involvement. So there is something called seeping, wax seeping sort of a picture in the choroidal retinal structure. So there can be nodules present in the choroid and retina also. So when we look at the clinical literature on the profile of clinical presentation, so this was an access study which was done in 736 patients over 6 months. So as you see, lung is the predominantly involved, so 95%, followed by the skin and eye, and all other organs like liver, spleen, and all come after that. Even heart also can be involved, and neurologic involvement. So the patient we had who came with the multi-organ failure and predominantly respiratory involvement also had neurological manifestations in the form of neuromuscular weakness. So that was very unique. So that's why it got us interested to look into this literature. So there was this another study which came from Cincinnati, where they followed up 1,024 patients between 2002 to 2006. And this was the involvement, which is very similar. Lung is predominantly involved, followed by the skin and eye and other organs, so on and so forth. Here, if you see, the neurological involvement was much higher. As I said, our patient had neurological involvement, and she was put on, in fact, psychiatric medications with lithium for her neurological manifestations. And this patient was treated by a rheumatologist, but was not worked up for sarcoidosis. Again, case highlights that even in ICU, although the patient may have been seen by a rheumatologist, it is good to have a high index of suspicion for such conditions and diagnosing the condition, which we'll go through. So when you look at lungs, so this is a typical sarcoid lungs where you have a lot of sarcoid granulomas. So the stage 1 is typically they have only lymph node, and the sarcoid, the key aspect of lymph node is predominantly paratracheal. So the lymph node enlargement will be predominantly around the trachea and around the airways. Stage 1 is lymph node involvement around the trachea. Stage 2 is they have lymph node along with the lung infiltrates, and it typically mimics TB because even the lung involvement with infiltrates are more in the epiphysis than in the bases. So again, that mimics tuberculosis very much. And stage 3 is predominantly only lung infiltrates. That is stage 3. And stage 4 is all these fibrotic changes that happens. And there is an advanced stage where they can have obstructive sort of a features in the lung. So they can obstruct the bronchi, so which is a much later advanced stage, and they can collapse the lung and all, so on and so forth. So these are the lung involvement stages. And as I said, lung is most predominantly involved in 90 to 94%, as you saw from the data. So I'll just take you to a pictorial representation of other organ involvement. So skin, they can have this maculopapular rashes, hyperpigmentation, and they can have non-specific skin rashes, and they can have erythema nodosum and the subcutaneous nodules, which are very painful and tender. And the lupus pernio is very sort of a unique to sarcoidosis, where they can have red sort of a rashes around the nose and around the oral cavity. And this is typically how the lupus pernio looks. So typically red areas around the nose. And in extreme cases, because of if eyes are not seen and all these granulomas are not seen, and there is a choroid and retinal involvement, they can have blindness. So liver is involved in 20 to 30%, where they can have increase in the alkaline phosphatase. And kidneys are involved with nephritis in less than 5% of the cases. Some of them can advance into renal failure also. So they can have a lot of muscle pain, which is also a characteristic of sarcoidosis. Cardiac, they can present with heart failure and arrhythmias due to involvement of the conducting pathways. And they can have bony pains, and bone marrow involvement also is common, where and they can present with lymphopenia. So the case we had in our ICU who presented with respiratory failure and neurological manifestations came with leukopenia. So had a total count of, I think, 1,000, and then slowly it improved. So lymphopenia is something that is common in sarcoidosis. And neurological involvement can happen in 5 to 10% as from the literature. And they can present with all non-specific. They can present with aseptic meningitis, or they can present with lymphocytic meningitis. They can even have paraplegia. So our patient had more of neuromuscular weakness and some neuropsychiatric issues she presented with. So they can have any sort of a neurological, but predominantly aseptic meningitis, inflammation of meninges, or lymphocytic sort of a meningitis is something that is described. Hypercalcemia can be present in 10% and there can be hypercalcemia. So this is just a pictorial representation for you to recall because it is a systemic disease. It pretty much involves every system. And so this is some of the clinical spectrum that you could find in sarcoid. So with regards to investigations, so chest X-ray, if you are able to pick up adenopathy and infiltrates, so that is something that you could pick up. But CT would be more sort of a crucial or definitive in trying to ascertain the type of adenopathies they have. So the lymph nodes more than 2 centimeters around the trachea should raise the suspicion and should need evaluation. So CT would be useful in trying to definitely look at possible diagnosis of sarcoid. And serum ACE levels, which we did for our patient, was very high. So it was around 23. So the levels should have been less than 5. So in acute sort of a sarcoid, serum ACE levels increases in about 60%. Although this is a non-specific indicator. So in acute, it can go up to 60%. In chronic, serum ACE levels may be high in 20% of the cases. But the problem with serum ACE is this ACE levels can be high in any infiltrative disease. So even in tuberculosis, miliary TB, Gauchers, or leprosy, serum ACE levels can be high. And the PET scan or the gallium scan shows areas of granuloma. So there is a unique sort of two classic findings that is found in sarcoid, which may be useful for all the trainees who are writing MCQs. There's something called Panda sign. So in Panda sign, basically there will be involvement of the lacrimal gland, parotid gland, and nasopharynx, which will be predominantly highlighted because of infiltrative problems in this area. And this is called Panda because it looks like panda. So lacrimal gland, nasopharynx, and the parotids. So this is Panda sign, which is typical of sarcoid. There's another sign called lambda sign. It looks like lambda. So lambda, again, as I said, and which I said earlier also, predominantly tracheal lymph nodes are involved. So lambda side is indicated by pretracheal lymph node involvement, right paratracheal lymph node, and left paratracheal. Basically, the trachea, how it looks like lambda. So lymph node enlargement around the trachea is what is seen as lambda side. So these two may be useful for MCQ answering. I'm sure most of the trainees who are listening to this are about that MCQ aspect. So now we look into the diagnostic pathways that has been created. So when patient is referred for possible, or if there is a index of suspicion of possible sarcoidosis, the key element which picks up the diagnosis is biopsy. So the way we picked up sarcoid in our patient was in bone marrow biopsy, which showed sarcoid granulomas. So here biopsy, if it shows granuloma, so most often the diagnosis is picked up by using endobronchial ultrasound and doing a lymph node biopsy. So that is the easiest. Or if you have a skin lesion or if you have an eye granuloma, that would be the easiest to pick up granuloma. But our patient did not have skin manifestations, neither did she have eye involvement. So bone marrow was done to evaluate for lymphopenia and PO workup, and that's picked up. So biopsy shows granuloma and there is no alternative diagnosis. And if it's clinically consistent with sarcoidosis, you make a diagnosis of sarcoid. So that is the easiest way. So otherwise, you have to look for, again, features of lung features. You have to look for the skin features and eye features. And you can look for surrogates of hypercalcemia and hypercalciuria as a reason. And if they are there, you have to reach out for any organ, as it's mentioned, bronchoscopy or any other organ where biopsy is possible. So biopsy with granuloma or needle aspirate showing granulomas remains quintessential for establishing diagnosis of sarcoidosis. If that biopsy shows and no alternative diagnosis, you make a diagnosis of sarcoid. If biopsy does not show, if it is negative, then the question remains as to what we should be doing. So if biopsy is negative but no evidence of alternate diagnosis, then you have to do serum ACE levels. As I said, our ACE levels were high. So serum ACE levels more than 2 times upper limit of normal. On bronchoalveolar lavage showing increase in the lymphocytes more than 2 times of upper limit of normal. And you have to resort to doing PET scan or gallium scan to look for Panda and lambda sign, because Panda and lambda figures where biopsy becomes negative. And if panda lambda sign is seen with increased ACE, then sarcoidosis can be made, and diagnosis can be made. If none of these are present, then still there could be sarcoidosis if no other alternate diagnosis is available. So this is the diagnostic sort of a pathway for sarcoidosis. With regards to management of sarcoidosis, you have to divide into three categories: whether the patient has minimal to no symptoms, or whether only single organ disease, or symptomatic with multiple organ involvement. If it is minimal to no symptoms, one has to look for again involvement of lung, or involvement of skin, or involvement of eye, and look at the calcium. And if no symptoms, no treatment is needed. But if symptoms arise, then possibly some therapy may be needed. But if there are no symptoms, no treatment is needed for sarcoid. If there is a single organ disease affecting mainly eye or the skin and mild respiratory symptoms, local therapies, local steroid applications, topical steroids can be tried for eye and skin manifestations. And systemic is only needed when there is no response to this treatment. But if there is multiple organ, like our patient who had multiple organ involvement, systemic glucocorticosteroids, prednisolone, or any of the systemic steroids have to be used. And steroids have to be tapered to less than 10 milligram in less than 6 months, which means in 6 months, you should bring down the steroid to less than 10 milligram. So if you are not able to bring down to less than 10 milligram within 6 months, because patient continues to remain symptomatic, then disease-modifying drugs like methotrexate, hydroxychloroquine, and dazotheprin have to be added. So our aim is to start steroid and taper it to less than 10 milligram in 6 months' time is what is been recommended. So drugs used to treat sarcoidosis: prednisolone 20 to 40 milligram once a day, and taper to 5 to 10 milligram and bring it to less than 10 milligram in 6 months should be the aim. Hydroxychloroquine can be used as a disease-modifying agent, and methotrexate 10 mg once a week and 2.5. So these are all standard disease-modifying agents for these conditions. And azathioprine 50 to 150 mg once a day and 50 to 200 mg once a day as maintenance. And infliximab in someone who is refractory to steroids could be considered at 3 to 5 mg per kg every 2 weeks for 2 doses, and then after every 4 to 8 weeks, every month or every 2 months has to be considered. So this is a overview of the treatment, and the diagnostic and treatment algorithm is what we touched. So it's just a brief overview, just for all our trainees to understand a little bit about sarcoidosis, the clinical paradigm. So it is not unusual to find such a patient coming to one's ICU with multi-organ involvement, where extensively worked up outside, but we have not hit a diagnosis. Sometimes you have to reach out for a, not sometimes, many times we have to reach out for a tissue biopsy to establish diagnosis. So in our patient, the diagnosis came with bone marrow. Maybe if diagnosis doesn't come in bone marrow, still there are other modalities one should keep in mind. So look at ACE levels, and always I say, tell my trainees to do calcium levels, because calcium can be a very surrogate marker for a lot of infiltrative problems. So these are some things that one could adopt to establish diagnosis. So thank you, one and all. So end with this beautiful quote: intellectual says a simple thing in a hard way, an artist says a hard thing in a simple way. So quite a effective quote. So thank you, one and all.